Hi everybody, I'm Dr. Tracy Papa. I'm a maternal fetal medicine specialist here in Fort Worth, Texas, and today I'm super excited to be interviewing pediatric neurosurgeon Dr. Ian Heger. He's here from Medical City in Dallas, and we're going to talk about what your visit might look like if your baby, if your fetus that you're expecting has a neurologic abnormality. Sometimes babies have extra fluid in the head, sometimes they have an opening in the spine, an open neural tube defect called Spina Bifida, and there are many other varieties of these that may require that your baby have surgery or have a surgical consultation after delivery. So we're going to talk with Dr. Heger about what this looks like during the interview process prenatally. Let's start with how you became a pediatric neurosurgeon. Were you interested in surgery? Were you interested in pediatric surgery? How did you get started?
It got started towards the end of medical school, where the idea started to materialize. Just by happenstance, I happened to do a lot of some of my electives in pediatrics, and I got to know a lot of the pediatricians there, and I always enjoyed, being around kids. And I did my residency at the same institution that I did my medical school rotations. And through my general surgery internship, I did 2 rotations through pediatric surgery. Again, was decided for me. But then I started spending more time on the pediatric wards and getting to know people. And there, as a resident in neurosurgery, all those bonds seemed to come into play. And I just enjoyed working with children and the pediatricians. In particular, I enjoyed the surgical problems that we encountered in the pediatric realm. So by the end of my residency, it became pretty clear that spending another year of training to further specialize in pediatrics was something that I wanted to do in my career.
As an aside, during my pediatric rotation, I decided I did not want to do that because I love kids, but unhappy kids, screaming kids, it just stressed me out. So I think you have to have a really special gift to be able to embrace that and be really good at it.
I see it as a calling. Clearly, it was something that I enjoyed. At the same time, realizing it's one of the things that I enjoyed about it turns people off. So it became clear that, I had the ability, I had the interest, and, it made sense for me to continue along that path.
Well, when a pregnant mom comes to see you knowing that she's expecting a baby with an abnormality that may require surgery, what are the typical problems that you see? What are the things that you see the most of prenatally?
Yeah, probably the 2 most common things are spina bifida and ventriculomegaly, or increased, fluid volume inside the brain.
So let's start with spina bifida, open neural tube defects. Those can happen anywhere along the spine, right?
Yes, they can. Probably more commonly, we see them lowered in the lower back area, but they can occur any place that you have spine. As babies start off in the process of developing, the baby starts off as a disc of tissue, and right in the middle of that is a streak that ends up becoming the nervous tissue, but it's on top. And about 4 weeks into development, changes happen where the tissue rolls over that neural tissue, and that tissue ends up getting into the place where it ultimately will become internalized and form a brain and spinal cord. With spina bifida, for whatever reason, at those particular locations, that rolling over doesn't take place. It's more common to occur at the ends, but it can occur any place along that process. And when that rolling over doesn't occur, as the rest of the baby develops, you end up with a portion of the spinal cord that's actually stuck on top of the skin.
So there are surgical options for this, right? What do you tell people about that? Not everybody's a candidate for it, and outcomes vary.
Yeah, outcomes vary, but and we do offer that, the fetal procedure at Medical City Children's Hospital. One of the reasons why I chose to come here. So that is available to patients. There are some rigorous criteria that they need to qualify for. It has to be diagnosed at a certain age, and we can't have other anomalies that occur along with it. But that is something that we offer to patients where it's indicated. Where it's not, we can still do, and we do quite often, the more traditional closure once the babies are born.
Good. So I know that patients go through a multidisciplinary interview process when they're considering fetal surgery for an open neural tube defect, and I think most people don't realize what's involved. But not every baby is a candidate for surgery, right?
Right. Because it's not only the baby that we're concerned about the mother too. So there are certain health requirements that we need to make sure that the mother is going to be doing fine with the surgery. Because what we do know, and this is one of the biggest concerns about doing this procedure in utero, it's for the baby, although spina bifida is a life-altering problem, it's not life-threatening. And what we certainly don't want to do is a procedure which puts the baby or the mother life at risk, to do something where we know if we wait until the baby is born, the baby is going to live perfectly fine in most circumstances. But we do know from the research that's been done in the past that we can increase motor function in the legs on these babies by doing it earlier in utero. But again, health is what's most important, and survivability is what's most important. We want to make sure that we can guarantee that for both the mother and the baby.
That's good. The way I understand it, I mean, they have to be the right gestational age to be able to operate in utero. They have to clearly understand the procedure and be on board with that because complications happen. Preterm labor, obviously ruptured membranes, infections can also be a part of that. And there can't be any other major anomalies. Do you require amniocentesis before, or to know what the chromosomes are before offering fetal surgery for this?
Yes, we do. Again, we want to make sure to do this surgery, we need to make sure this is the only problem that we're dealing with, that there's not other issues that are involved that might affect, the survivability or anything else with respect to the baby.
I think that's great. So in other types of the neural tube defects that are not down low, what are the options? Is there generally a more poor prognosis the further north the opening is?
Generally speaking, yes, that is the case. But it's certainly not, nothing is written in stone. And that's, again, back to what we were talking about before. One of the things that I really liked about working with children was that even in the grimmest circumstances, when you have the younger the child, the more potential they have, particularly when it comes to the brain, for them to make a recovery. Children are so malleable, and the brain is also the same way. So although we have our rules based on research in the past, that the further up you go on the spinal cord, the worse the prognosis. It doesn't necessarily mean that that's the case. Just because 90% of the people do badly doesn't mean that each child is going to do badly.
Yeah, and parents always want to maintain as much hope as possible. How do you find that balance, giving them hope and being realistic about outcomes? I'm just realistic. I tell parents, what the situation is, even if it's grim, and I give them what other options, are at my disposal. If there's something that I can do and intervene and, change the equation, then, we'll put that into play. It's much easier
to be aggressive, particularly on the surgical realm when you're dealing with children. Again, another reason why I chose to go into pediatrics. It's easier to justify, swinging for the fences, because there's more of an opportunity to hit home runs, and I like hitting home runs.
Yeah, I mean, we always want the best for kids in particular, and you can make such a profound difference repairing something or helping something early on because they are so malleable, and sometimes outcomes are surprisingly good. Well, tell me about ventriculomegaly, and this is extra fluid in the ventricles or the fluid-filled chambers in the baby's head. When we're looking at this with ultrasound prenatally, normally the lateral ventricles should have no more than about 10 millimeters or so of fluid in there. And if there's just a little bit of extra fluid, sometimes that's simply a normal variant and no treatment is required at all. But when we send somebody to see you because there's extra fluid in the head or another type of brain abnormality, what do you talk about with the parents?
Yeah, probably the first thing that I talk about is the child may not require surgery, because I have seen, things change quite remarkably. Sometimes that little bit of extra fluid really is a function, of the brain just being slow to grow and to develop, because I've seen many cases where we thought we had ventriculomegaly, and once the baby is born, we're able to image the baby directly rather than through the uterus. We see a different picture, and we see the ventricles are fine, and those children end up doing great. So the first thing is, in many circumstances, particularly when the ventriculomegaly is mild, to let parents know that this may not be abnormal. We may be perfectly fine after everything is said. The other thing that I tell them is that we're going to do direct imaging of the baby once the baby's born, and that gives us a lot more information. The ultrasounds, we're going through so much tissue before we even get to the baby. It's hard really for me to make a surgical plan based on that. And the fetal MRIs are much, much better and give us so much more information. But still, we're talking about a tiny baby. Even when the babies are born, that the size is so small when we put them in the MRI machine, the resolution isn't that great. So, I let them know, what the option, if we have to do surgery, what the options might be, but we're not making any decisions until the baby's born.
That can be frustrating for moms who come back from a prenatal consultation and say, well, nobody would commit themselves, but that's simply because every baby is different. And we have the disadvantage of looking at babies through moms, which means we have no control over what position they're in. And this is true for fetal MRIs as well. You just have to take what you can get. But after delivery, when we're imaging babies directly, it's easier, even though the resolution may still not be so great.
But I will tell you another thing. I mean, my perspective of that visit isn't only to give answers, but and it's an opportunity for me to meet the mom and vice versa in a very controlled setting. And this became apparent to me, the power of that meeting, once I started doing them, because I was used to particularly as a resident, and then early in my career, meeting these moms immediately after delivery. And whether it's a C-section or a vaginal delivery, I've never encountered the mother on the day of birth that's comfortable and isn't getting medicated. So the first time to be meeting the surgeon who's going to be taking care of your child and might actually be operating with the next day or two, that's probably not the best setting. I certainly notice from my perspective that it's, for obvious reasons, it's very difficult to carry on a conversation in those settings. So even if you don't get all your questions answered on that prenatal visit, a lot is still accomplished.
I agree. You would be surprised, or perhaps you already know, that not every pediatric surgeon wants to do a prenatal consultation. But when we schedule them, we try to do it in the third trimester so that they remember the surgeon remembers them. You can remember a little bit of the conversation, and you know kind of what trajectory this problem is taking. Is the ventriculomegaly getting worse quickly? Do we have a fetal MRI to be able to send with them? So we really appreciate, I know that our patients appreciate being able to meet with the surgeon beforehand, not when they're hurting, not when there's 12 people around them starting IVs. So when we have a prenatal diagnosis, this is so very helpful for them to be able to come and see you.
Yeah, and that's why I do it. It really helps the process of me taking care of their child.
Well, what else do you want parents to know? In your experience, what questions don't they ask that you wish they would, or what do you think they need to know in general?
I think they need to know who their surgeon is. I think they need to know what the surgeon is thinking. From that point, realizing, of course, the plan may change once the baby is born. The logistics of, okay, I'm going to deliver and the baby's going to be born. Am I going to be able to see the baby before or after surgery? That's probably, it's not a question that I necessarily get asked at Medical City because the answer, they're in the same patient tower. But it's probably a good question for mothers to ask, particularly since a lot of the big name children's hospitals in the country is actually you'd be separate from your baby. So that's probably a question that I don't get asked that probably nationwide is an important one for moms to ask.
I think you're right. People don't think to ask that, and it's kind of an obvious question, but in thinking through what path their delivery is going to take, it's something that not enough people ask or they don't realize until the time comes. Thanks so much, Dr. Heger, for talking to us. This is going to be so helpful to our patients.
It's been my pleasure.
For more great content like this, keep in mind that we're going to be interviewing other surgeons and physicians, pediatric specialists that you might be seeing during the course of your pregnancy if your baby is diagnosed with an abnormality. For this and more great content, head over to the blog, drtracypapa.com, and subscribe.